Welcome, everyone, to this program, which, as you can see, is entitled Integrating Quadruplet Regimens in Newly Diagnosed Multiple Myeloma, Patient-Focused Strategies to Improve Outcomes. This activity is provided in collaboration with Rush University Medical Center and Practice Point Communications, and supported by independent educational grants from Janssen Biotech, administered by Janssen Scientific Affairs, LLC. It'll be my privilege to moderate this session. My name is Bob Orlowski. I'm the director of the myeloma section at the University of Texas MD Anderson Cancer Center in lovely, cool, and dry Houston, Texas. And you can see my conflict of interest statement here. We also have a wonderful additional panel of faculty, including Dr. Nupur Raje, who's the director for the Center of Multiple Myeloma at the Massachusetts General Hospital up in Boston, Massachusetts. Here are some of her conflict of interest statements. And then, of course, we also have Dr. Peter Voorhees, who's the chief of the Plasma Cell Disorders Division at Atrium Health and Levine Cancer Institute at the Wake Forest University School of Medicine in North Carolina. These are our learning objectives. Hopefully, upon completion of this material, participants should be able to review the latest criteria and methodologies for risk stratification of patients with newly diagnosed myeloma. You'll be able to recognize the efficacy and also the limitations of the available and emerging triplet regimens for various patients in the newly diagnosed setting. Also to evaluate the safety and efficacy of approved and emerging quadruplet combinations, which I think we're all excited about and is one reason why we're here. You'll be able to differentiate the utility of available and emerging quadruplet versus triplet regimens based on clinical endpoints and adverse effects, and this will be in a variety of molecular and stage settings, including low, standard, and high-risk patients, and you'll be able to employ individualized strategies to choose frontline and also subsequent therapy for different newly diagnosed myeloma patient subsets based on their individual requirements while reducing and optimally managing adverse events. We'll start with segment number 1, which I will present, which is an overview of risk stratification of patients with newly diagnosed multiple myeloma. As you know, myeloma is characterized by a clonal expansion of aberrant plasma cells, mostly in the bone marrow, although occasionally, even in newly diagnosed patients, some may have extramedullary disease. There's almost 180,000 people living with myeloma in the United States as of 2021. That number is increasing in part because the incidence of myeloma is going up a little bit, and also the 5-year survival is going up. As you can see, it's at 61.1%. So that means that the prevalence is going up as well. For 2024, there'll be about 35,000 to 36,000 new cases diagnosed and about 12,540 deaths as a result of myeloma and its complications. Clinical presentations of patients with symptomatic myeloma can include bone pain, either with or without lytic lesions. Often, if they're present, they're discovered on routine radiographic films or other imaging. It's also not uncommon to see an increased total serum protein with sometimes a low albumin as well. And if a protein electrophoresis with immunofixation is done, you'll find a monoclonal protein or a free light chain in the serum or urine in the vast majority. Patients can have systemic signs or symptoms suggestive of malignancy, including, for example, anemia, hypercalcemia, of course, due to bone damage, and sometimes renal insufficiency can be a presenting symptom, and acute kidney failure with a bland urinalysis, or occasionally nephrotic syndrome, which, if present, should raise concern about a concurrent amyloidosis. These are the revised International Myeloma Working Group criteria for diagnosis of myeloma. Typically, patients should have at least 10% clonal involvement with marrow plasma cells, or they can have a biopsy-proven plasmacytoma, and you need to have at least one of the criteria shown below under the CRAB or the SLIM criteria. The CRAB are the older criteria that probably many of you are familiar with, which include hypercalcemia or renal insufficiency or anemia or bone lesions. And then within the past about 5 to 10 years, the so-called SLIM criteria were added, which means that if you have at least 60% clonal bone marrow plasma cells or an involved to uninvolved free light chain ratio of 100 or more, or if you have more than one focal lesion on MRI that's at least 5 millimeters in size. So any one of the CRAB or SLIM criteria are enough to put you into the category of symptomatic multiple myeloma. This table shows you how to easily differentiate MGUS from smoldering and active myeloma. The people with MGUS typically have a low level, less than 10% clonal marrow plasma cells, and usually have a low level serum and or urine monoclonal protein, with none of those myeloma defining events that fall into the CRAB or the SLIM criteria. Smoldering myeloma patients typically have more disease, with bone marrow involvement that ranges from 10 to 59%, and often will also have an increased serum or urine protein, but also will not have any myeloma defining events. And then finally, symptomatic myeloma, as we reviewed, is at least 10% plasma cells in the marrow or a biopsy plasmacytoma. Really, any level of monoclonal protein is sufficient, and the defining feature is the presence of one of those myeloma defining events, again, in the CRAB or SLIM categories. Here are some polling questions to start with. Which one of the following best describes smoldering multiple myeloma? And we'd love for you to vote on this. Your options are A, less than 10% clonal bone marrow plasma cells and a serum M protein level of less than 30 grams per liter. B is 10 to 59% clonal marrow plasma cells and or a serum monoclonal protein of 30 or more gram per liter. C is 10 to 59% clonal bone marrow plasma cells. D is 10 to 59% marrow plasma cells and the serum M protein below 30 gram per liter. And E is 10% or more bone marrow involvement or a biopsy-proven plasmacytoma. The majority of people on the program are voting for option B to define smoldering myeloma, which means 10% to 59% clonal bone marrow plasma cells and or a serum monoclonal protein level of 30 or more gram per liter. Dr. Voorhees, do you want to walk us through which one of these is the best answer in your mind?
So I think that the audience got it absolutely right. So either a bone marrow burden of 10 to 59%, or an M protein of 3 grams per deciliter or higher. And if you're a free light chain patient, monoclonal light chains of 500 milligrams or higher in a 24-hour urine would be the right answer.
Excellent. So we've got a well-versed audience, so that's always good to know. This slide provides you with an overview of the initial evaluation of patients with myeloma and factors that you may want to consider in deciding on the best treatment. Some of these are patient-related factors like age, frailty, comorbidities, kidney function, and their access to care, which can mean not just whether they have optimal insurance or not, but, for example, how far away from your office or clinic do they live. Disease factors are important, including how aggressive the disease is, whether it has high risk or standard risk molecular features, biochemical abnormalities, prognostic scores, and of course, staging. And then finally, transplant eligibility is still something that we very much consider, and important factors there include age, cardiopulmonary, renal, hepatic function, and other considerations. We mentioned briefly about the role of frailty assessments, and there are a few different ways that this can be done. Traditionally, we've looked at this through either the Karnofsky performance status or the so-called ECOG, or Eastern Cooperative Oncology Group performance status, and many of these are incorporated into clinical trials. For example, typically most trials want patients that have an ECOG of either 0, 1, or 2, and the main defining feature is that if you're at an ECOG of 2, you're up and about for more than 50% of the waking hours, whereas if you're an ECOG of 3, then you're up and about for less than 50% of that time. There also, importantly, and I think we'll get to this a little bit later, there is an International Myeloma Working Group frailty calculator. The web address for that is shown here. And I think this is a really important tool for those of you that see patients that you think may be frail, because we are at the point where we can now choose different therapies based on whether patients meet these criteria or not. From a molecular perspective, patients with myeloma typically fall into about half of the population who have hyperdiploid disease. This essentially means that they have more than one copy of certain chromosomes. Sorry, that should be more than two copies, typically of the odd number chromosomes. And then the other half of patients have IGH translocations. As you can see, the most common are the 1114 with cyclin D1 overexpression, and then 414 with NSD2 overexpression. And there are other classifications as well that are less common, like the 614, 1416, and 1420 translocations. Based on those results, we can typically risk stratify patients into either standard risk, which includes those that have trisomies or hyperdiploidy, and 1114 as well as 614 are considered standard risk as well, while high risk is considered 17p13 deletion, 414, 1416, 1420, gain or amplification of 1q, high LDH, plasma cell leukemia, and if you do gene expression profiling based on one of two different assays that are available, you can also have a high-risk gene expression profile signature. Please note that there is an upcoming revision of the high-risk definition coming from the International Myeloma Working Group, so hopefully that will be out fairly soon as well. In terms of staging, this is the current revised international staging system, where you take the results of the beta-2 microglobulin, the albumin, and the lactate dehydrogenase, as well as the FISH data from the bone marrow. Patients in stage 1 have essentially a low beta-2, a normal serum albumin and LDH, and standard risk chromosome abnormalities. Patients in stage 3 have a high beta-2 and either a high LDH or a high-risk cytogenetic feature, and patients in stage 2 are those that don't fit either stage 1 or stage 3. Also, it's important to remember that the beta-2 is not corrected for renal function, so the patients who have renal insufficiency and a high beta-2, you take the beta-2 as it is. In general, the treatment paradigm is shown here, where you look at factors that can be considered for stem cell transplant, which include, as we mentioned, age, performance status, comorbidities, and organ function. And in general, we try to divide people up into those who could be eligible versus those who would not be eligible for stem cell transplantation. The goals of therapy are shown here, which is to achieve a deep response and a durable response, to reduce and hopefully completely get rid of symptoms due to myeloma and its complications, improve quality of life, and of course, achieve long-term survival. Here's the next polling question. Which one of the following aberrations are associated with standard risk myeloma? And your options are A, 17p13 deletion, B is the 414 translocation, C is the 1416 translocation, D is the 1114 translocation, and E is the 1420 translocation. Who knows, this may be on your upcoming long-term knowledge assessment that you're doing for your ABIM maintenance of certification. Looks like so far the majority of people are voting for the 1114 translocation. And Dr. Raje, maybe you can walk us through this question so that folks have the right answer when they're done with their polling.
Yeah, no, I think, as you pointed out, the majority of patients people have picked option D, which is the correct option in this case, Bob. 1114 is considered standard risk, so you have a really well-educated audience. What we typically consider anything to do with the 17p or p53, in this case, the 17p deletion is considered high risk, as well as some of the other high-risk IgH translocations, as you pointed out, 414, 1416, 1420, 1114, which overexpresses cyclin D1, which you so nicely alluded to, is considered standard risk. And I think it's important for folks to understand and recognize that it exists because we do have a targeted agent which can be used in patients with the 1114 translocation.
Excellent. Well, thank you very much. Here's a summary of this first section. Keep in mind the CRAB and SLIM criteria to differentiate between myeloma that is smoldering versus active. Remember to assess fitness and frailty among patients, which is really important to managing and determining transplant eligibility, and use the frailty calculator that you'll also see again later. Cytogenetic and molecular data are definitely increasingly important in differentiating risk and also now are important in determining therapy. And so there is a strong rationale to risk stratify all patients with myeloma to get the best therapies available.